Hi everyone. So today what we're going to do is we're going to be talking about part one anatomy of the abdomen and pelvis for your exams. The first organ we're going to talk about is the liver. The liver is divided into 9 segments, and these are important to know. I'll show you a good way of remembering it, but vertically they're divided by the hepatic veins. So you've got the right, middle, and left hepatic veins, and then horizontally, they're divided by the portal vein. So you've got the main portal vein, towards the left you've got the left portal vein, and on the right you've got the right portal vein. In the top left, you've got the second hepatic segment, then you've got the third, then you've got 4B, then you've got 5, 6, 7, 8, and then 4A on top of 4B. And then behind this is segment 1, so the caudate lobe. This is a CT of those structures. So over here, you've got the right, middle, and left hepatic veins. Just to the left of the left hepatic vein, you've got segment 2. Beneath it, you've got segment 3, and then you've got segment 4B, and then you've got segment 5, 6. Sorry, these aren't actually written here. And then 7 is near the diaphragm, 8, and then 4B is there. A good way to remember it in the exam is actually to just make a fist, and you can actually work back to first principles from here. Between the knuckles, the ridges, those would be your hepatic veins, and then across at the level of the sort of this level, those would be your portal vein plane. The thumb will be your caudate lobe, which is easy to remember because it's just not one of these. And so this one, so you get 2, 3, 4B, 5, 6, 7, 8, 4A. 4A is above 4B is the way to remember it. And then 2 is the most lateral, superior lateral, and 6 is the most superior medial, inferior lateral. The next structure is the kidney. The things to remember about the kidney are that the outside part is called the cortex. This then has little bits that sort of traverse inwardly, called the columns of Bertin. And then you've got the medullary pyramids, which are here. At the tip of these pyramids, that's what produces urine, and they drain into the calyces, which have several levels, which we'll talk about later. That then drains into the renal pelvis and then proximal ureter. The retroperitoneum is the next thing to know about. You've got different fascia, which they do test. The anterior renal fascia is also known as Gerota's fascia. You can use either or. If you can remember Gerota's, I think it's worth using it. It's one of the ones that I remember that actually I use Gerota's fascia. But if you can't remember on the day of the exam, I think anterior renal fascia should be fine. Zucker-Candle's fascia, Z is a late letter, and so you remember that's posterior. G is before Z, so Z is posterior. That's the posterior renal fascia. It's quite easy to see on CTs and MRIs, and so this would be Gerota's fascia. And then lateral conal fascia is the one lateral, and that's this. And that envelops the ascending and descending colons as well. And those are the main structures to remember in the retroperitoneum. The biliary tree, you've got all the little bile ducts that then form bigger ducts. You've got the left and right hepatic ducts, which then create the common hepatic duct. In the liver, the common hepatic duct is called the common hepatic duct. When it leaves the liver and it's outside of the liver, it's called the common bile duct. That then joins with the cystic duct, and then the pancreatic duct normally joins it, and that exits via the major papilla or ampulla of Vata, which drains into the second part of the duodenum. The sphincter ovodi is that muscular thing that surrounds it and then releases and relaxes whenever bile needs to be released. On ultrasound, you got to remember a couple of things. So the CBD runs anterior to the portal vein. So portal vein, CBD, and then lateral to the hepatic artery. It's not got a picture of it here. But remember, if something is running alongside the portal vein, it's probably going to be the CBD. CBD running alongside or anterior to the portal vein and then lateral to the hepatic artery. Okay, so hepatic artery would be a small dot here sometimes, and it runs in a different plane, so it's quite hard to, you don't always see it. Obviously, in normal practice, you'll use color Doppler to distinguish between them. However, in the exams, they might not give you a color Doppler sort of image. Again, the lower part of the biliary tree here, you've got the CBD that joins with the duct of Wirsung, which is normally the main thing that drains the body and tail of the pancreas. The duct of Santrini exits via the minor papilla and normally drains the head. You get variants, which we'll talk about, where this slightly changes, but always remember that the CBD drains via the ampulla ovata, or the major papilla. And yeah, don't get tricked by any variants. This always drains via that. The variant to be aware of is pancreas divisum. This is where the ventral duct or duct of Wirsung only drains the head, and actually the main pancreatic ducts drains via the duct of Santrini into the minor papilla. Remember, CBD always drains via the major papilla. The stomach is quite straightforward for you guys, probably. It's same stuff as med school. If they point to a part of the stomach, you should name it in the exam. And so esophagus, cardia, fundus is the top end, the body is the big part, the antrum is where it starts to become a bit horizontal. The pylorus is the muscular thing which releases and contracts when food needs to get through. And then the duodenum is the first part of after that. The duodenum is also divided, so after the pylorus, you've got the first part of the duodenum. This part is called the duodenal cap. You can call it the duodenal cap if they literally point to the top wall of the first part of the duodenum, but actually, I would probably just go for first part of the duodenum if you're not sure. You'll always be right. Second part is this vertical bit, where you've got the major papilla draining into. Third part is the horizontal bit. Fourth part is as it starts to come up. And then you've got the ligamentum teres, where the DJ factor is, where it joins with the duodenum. They like testing the musculature of the anterior abdominal wall. This is actually quite straightforward. You've got the linea alba connecting the two rectus abdominis muscles. I think these are called hiatus semilunaris. These aren't labeled. It's something semilularis. I think it's hiatus semilularis, which is between the rectus muscles and the oblique muscles. And then in the oblique muscles, you've got the external, which is on the outside. You've got the internal, which is just internal to it. And then you've got the transverse abdominis, which is just internal to the internal obliques. Let's go through some cases, starting with some plain films. They're pointing at stomach. On this, it's hard to tell what part they're pointing at. I think if you say body of the stomach or stomach, it should be good. I would personally go with body because they do try and, this can't be anything else apart from body of the stomach. B is the left properitoneal fat strap or line. You can see this on X-rays, and it's the fat layer between the peritoneum and the oblique muscles of the lateral abdominal wall. C is the pedicle. Remember the owl eyes, one eye, second eye, and we know that they're pedicles. This is the 12th vertebral body because the 12th ribs come off it, so this has to be L1. So this will be the left pedicle of L1. D is the transverse colon. You know this is colon because these are haustra and not valvulae conniventes. These don't go across the entire length, and so this is large bowel, and it looks like transverse colon because it's coming like across the abdomen. And then E, they're pointing to the shadow of the right psoas major muscle. They do like showing this thing, it's faintly seen, and, the psoas comes like here and then attaches to the hip at the lesser tuberosity. Again, solid structures on X-rays, they do like showing, they've outlined the inferior pole of the left kidney here. So this is the left kidney. I think you can say left kidney or lower pole of the left kidney. B is the liver. You can see that the liver is coming like this. It's incompletely imaged, but it's a solid structure and it's right upper quadrant. So it's liver. C again is the right psoas muscle or shadow. E is the stomach. They may also show you an image like this. This is a neonatal abdominal x-ray, and they've shown a few catheters. There's one umbilical vein and there's two umbilical arteries. The artery does a little bit of a loop. So the artery goes from the umbilical artery into the left internal iliac artery, and then left common iliac arteries, and then into the aorta. And because it's going into the iliac arteries, it's sort of going like this, and then remember the iliac arteries come down here, so it's sort of going up and then coming into the iliac arteries and then going into the aorta is the way that I sort of remember it. Whereas a vein, it goes from the umbilical vein into the left internal iliac vein, common iliac vein, and then IVC, and you can see it's going into the right, into the hepatic IVC on this side. Let's do some ultrasound. So this is a transverse ultrasound of the abdomen, almost like an axial CT. This would be the vertebral body coming straight down, just slightly to the left of the vertebral body is a big vessel. It would be the aorta, is E. To the right of it is the IVC. C, it sort of looks like a snowman on axial imaging, the SMA on the aorta. So that's the head of the snowman, that's the body of the snowman, and so this would be the SMA. And then to the right of it, to the left of it would be the SMV, which sort of comes up and then joins the splenic vein and then creates the portal vein, remember? I'll show it to you shortly. This is important actually for pediatric malrotation. So when you do ultrasounds to look for malrotation in some centers, you look at the orientation of these. If this is on that side or slightly less, or even in the middle, that would make you suspicious of malrotation. And then B is the head of the pancreas. Remember, the pancreas comes along like here. This is the head. Uncinate process would be around here somewhere. Body, tail, and then it would go towards the spleen there. This is an image of the liver at the level of the porta hepatis. And this is what we talked about sort of just now. So B would be the portal vein. You've done lots of liver ultrasound hopefully by now. And the portal vein looks like this. If you put some collar Doppler on, it would light up. Remember, just lateral to it, you would have the common bile duct. It sort of does go in a similar sort of course of the portal vein, and then somewhere in this area, again, you'd have the hepatic artery, but because it has that typical structure of the bile duct or the CBD, it is that the hepatic vein is normally actually not in the same plane as this, and it's normally like a little dot here. D is the IVC, the intrahepatic portion of the IVC. Call it the inferior vena cava, remember, in the exam, don't use abbreviations. And then C is the right lobe of the liver. It's hard to tell what segment this is, and so right lobe of the liver is good. Similar picture, this is the pancreas, this is the body, and then this is the proximal tail probably of the pancreas. If you say pancreas, it should be okay. I would go with actually tail of pancreas because it's already bent and it would count as the tail. 95 would be the left lobe of the liver. Again, you can't tell what segment it is at this level, and so don't commit, don't feel tempted to commit. To the left of the vertebral body, you'll have the aorta. 94 is the left kidney. This image they often do in pediatric cases to look for pyloric stenosis. So we're at the level of the pylorus. You can see this structure here that has a wall and content is coming down from the stomach up here, through here, and then into the duodenum. This is the liver, rectus abdominis muscle. So this would be the pylorus or pyloric canal is what the answer says. 98 is the head of the pancreas. Remember, we've got the aorta here, and then draped over the aorta and the splenic vein is the pancreas. The hepatic veins are quite straightforward. You've got middle, left, and right hepatic vein. And then when they're starting to point at things, when you've got this level, you know it's quite high up because remember the hepatic veins, they join the IVC quite high up just as it sort of pierces the diaphragm. So you should be able to tell what levels these are. Remember, in the exam, just make that fist, and actually you can't go wrong. If they give you, what segment is this, you'll be able to work it out from that principle. So 36 is the middle hepatic vein, 37 is the IVC, 38 is segment 8 of the liver. because it's the middle one that divides segment A, and then this would then have to be segment 4A of the liver, because it's one higher up. And then this hyperechoic structure at the level of the liver would be the diaphragm. Okay, so this is again at the level of the porta hepatis. So let's see the structures that we know. 46 is the portal vein. You know, it's got that look of the portal vein. It's coming horizontal and it's in sort of long axis at this level. 47 is the IVC. So, sorry, this is a LS view of the liver. So actually the probe is like this, and the liver is cut into a sagittal section. This is the IVC, portal vein. 48 is the hepatic artery, and then 49 is the common bile duct. And the way to remember is what I mentioned. You know, no matter what view you're looking at it on, the vein and the duct sort of like look like they're in the same orientation, whereas the artery comes at a weirder angle. So when you cut it, it's not in the same cross section as these two. And I think that is a good way to sort of have it in your mind. And then the next question is, name the opening into the lesser sac whose anterior margin is formed by the structures 4 of these structures, and that's the epiploic foramen, which we'll talk about. This is what I mentioned. So the CBD runs anterior to the portal vein and lateral to the hepatic artery. So remember, these go in the same direction or same orientation, vein and bile duct. Epiploic foramen divides the lesser and greater what are they called? I think cavities or spaces, and yeah, they are, the entrance is the epiploic foramen, which is at this level. So A, left lobe of the liver, aorta, and the structure that looks like this, it sort of looks like someone doing the splits. This vessel going down here would be the splenic artery. This vessel, like here, before any sort of divisions, would be the common hepatic artery. Remember, it splits off into a few others, which we'll talk about. So common hepatic artery, liver, left lobe, and then this is the vertebral body. This is an LS view. You can see that this vessel is in sort of longitudinal axis, and so this A is the liver. And specifically the left lobe of the liver. That's because E is the, actually, I don't actually think it's that easy to tell that this is the left lobe of the liver, because E is the IVC. The reason you know it's the IVC is because there's nothing coming off it. The aorta has the celiac axis, SMA, and IMA coming off it, and you can see these coming off like that. And so this would be the IVC. B is the hepatic artery, C is the portal vein, and then D is the CBD. Do you see vein and bile duct have like a similar orientation, and then the artery is just doing its own thing? So these are in LS, this is in transverse, and that's the way to remember. I don't think actually you can tell that easily what lobe this is, left or right. I think it's quite difficult. So this is, you have to ask yourself, where in the body is this? I don't know really where it is. And this is in the right iliac fossa. This is A is the appendix. It's actually it looks like a vessel sometimes. And it's really, really hard to see if it's not inflamed, but this is the appendix. Just next to the appendix posteriorly, you've got the iliac, divisions of the iliac arteries. So B actually is the, right external iliac artery. It says right femoral artery, but I don't think we're at the level of past the inguinal canal ligament at this stage, so it's actually quite difficult to say. So I would actually just go with external iliac. C is, apparently it's the psoas muscle. You can sort of see that it's going to come down here. It's quite difficult to say, but it's in the right area for it. And then D is the inferior epigastric vessels, specifically the artery here. They come off the external, the femoral artery and then come up into the body. And it's important when you're doing a abdominal drain that you don't go too medial, because then you can hit these and so you come quite lateral. I just want to show you this one because this is what the aorta would look like compared to the IVC. You've got a vessel coming off here, which is B, which would be the SMA. Remember, the SMA comes off like this. The celiac axis comes off a little bit higher and divides quite early on. Gallbladder. B is the IVC. C is the right renal artery. The renal artery goes posterior to the IVC. D is the portal vein. And E is the common hepatic duct. It's at the level of the liver, and so it's common hepatic duct rather than CBD. And you see how the vein and the duct are in the same orientation. So a kidney, we know that we can see liver, and so this would be the right kidney. So A would be the right lobe of the liver. B is the renal cortex. From the outside is called the cortex. C are the pyramids, which are slightly more hypoechoic. D is the renal sinus. So the renal sinus fat is it can look variable on ultrasound, but the renal sinus fat is bright. So that's what this is: pyramids, sinus fat, cortex. E is the capsule. A is a renal pyramid. C is the cortex. B is the sinus fat, renal sinus fat. And then D is the perirenal fat. This is a column of Burton, and then it's the cortex coming more inside. The recess between the right lobe of the liver and the right kidney is Morrison's pouch. You sometimes look for fluid there in trauma settings when they do fast scans in A&E. I think we've done this. This is that hypertrophied column of Burton that I talked about. Sometimes people, oh, is this tumor? But it's the same echogenicity as the cortex, and it's just like, yep, a hypertrophied column of Burton. So looking now down, this is a TVUS. The TVUS probe always has this. It looks like a half a circle, and this is the head of the probe. If you've seen those probes, they look very different to all the other ultrasound probes that we use. And so this is a transvaginal ultrasound. So this is an axial view. So you've got to think of this like a axial CT through the pelvis. This is the uterus here. This is anterior, this is posterior. So because this is the uterus, and specifically the myometrium is the outside of the uterus, C is the rectum, D is the rectum, back here, because this is an axial. A is the bladder. The bladder is being pushed a little bit out to the side here, but this is a bit of bladder, this is a little bit of bladder. It's just being pushed out the way a little bit, and we're quite low down. And then C is the endometrium, which is this hyperechoic structure here. And then within that, you've got the actual cavity. Sometimes you get a bit of fluid if someone's on there is menstruating. And this variant, because you've got one here and one there, it's called a bicornuate uterus. (16) is the urinary bladder. 17 is, again, the myometrium. Sorry, I should tell you. This is a sagittal view, transabdominal sagittal view of the pelvis. Probe is here on the abdomen. You've got a window because you've got them to fill their bladder, and so you can see the structures a little bit better. This is not as good as a TVUS to evaluate these structures, but you can't do a TVUS in everyone. And so sometimes you get them to fill their bladder, and you can see the pelvic organs a lot better when they've got a full bladder. So, 17 is the myometrium. This outside part is all myometrium. 18 is the endometrium, which is this hyperechoic line in the middle. 19 is the cervix, and then 20 is the vagina. So actually, introitus is out here, then the vagina, then the cervix, and then the uterus like this. So this is sagittal. This is an axial transabdominal ultrasound of the same structures. So, they've got the full bladder. So this is the bladder. B is the iliac vessel, so the iliac vessel's coming like this. I don't think they would show you or ask you what vessel this is. Apparently it's the left external iliac vessel. I think it's very difficult to say. I would have actually gone with one of the internal ones, and so maybe this answer is wrong because, we're quite deep. External will be going into the femoral arteries. Okay. C is the endometrium because they're pointing to this line rather than this, which is that little bit of cavity with a bit of fluid in it. And then D is the myometrium, or uterus. So sagittal TVUS, this is a TVUS because of that weird probe. And then the uterus, the fundus of the uterus is up here. And then the cervix is down here. So A is the cervix. B is the myometrium. C is the endometrium, this thing here coming like that. And then inside you've got the cavity. And then D is the fundus of the uterus. This is an ovary. This is what an ovary looks like on a transabdominal ultrasound. You've got these follicles, and then the ovary is this. And you've got the bladder as a nice window. This is a testicle. I'll show you a bit more anatomy of it later, but this is the testicle partially imaged. This is the top part of the testicle, but you can just call it you can just call it testicle. A is the head of the epididymis. I'll show you the anatomy of it later, but it looks like this. It just sits proud on top of the testicle like this. D is the scrotum. The probe is here, so this is skin. And then B is a testicular vein. It's quite hard to say actually without color, but it looks slightly serpiginous, and so this is a testicular vein. Remember, the left testicular vein drains via the left renal vein, and so if someone has a varicocele on the left, you always have to look at the left kidney to make sure there's no big tumor. There very rarely is, but it's sort of standard practice. Whenever you see a varicocele in the left, you look at the left kidney, because of that drainage. So we've got a full picture of the testicle here. So testicle or body of the testicle, I think you can say either. B is the epididymis. This is a terrible picture of it, and actually it's so hard to say what that is. This tiny little thing. The epididymis, I've got another picture of it later, is a lot more obvious than this. I put this in because I want to show you this. This is the mediastinum testes. This is a line of like tissue that comes in. I think it gives it a bit of structural support or something. But when they show you a line like this, this is the mediastinum of the testes. This is a vein. Sorry, this is apparently the vas deferens. I think it's very difficult, these posterior structures in this image. I don't think they'll give it to you. This is what the epididymis looks like. It's far more obvious on this image. C is the epididymis. So the head is here, which is B. The head of the epididymis, this comes into the body, and then the tail is down here at the inferior pole of the testicle. And then D, remember, is the scrotum because the probe is here. So testicle, A is the head, B is the rete testes. So basically, this is the mediastinum testes, this hyperechoic line. It's less obvious on this one, which is C, but around it is something called the rete testes, R-E-T-E testis. And actually, you can get some cystic sort of change here, and that's just called just some dilatation of the rete testes. You see it in quite a few people, and it's not a tumor. So that's why it's of clinical importance to basically say, actually, no, it's got the correct images, it's got the correct look for something which is benign. And then E is the vas deferens, but I think it's quite difficult to say. So we're going to go on to a little bit of fluoro. These are, this is an intravenous urogram. So they've given some contrast, they've waited a little bit, the contrast has eventually reached the kidneys, and then they take in x-rays. They don't really do this anymore. This is an old school sort of imaging technique. I've never seen one in real life, but you sometimes get this just like accidentally. Let's say someone gets an abdominal x-ray randomly and they've just had it at CT for whatever reason. You can sometimes see contrast in the collecting systems. So the kidneys surround this. This is probably the inferior pole of the back left kidney. And then this is an upper pole major calyx. These are minor calyces. These are a major calyx. This is a major calyx. This is a major calyx. And they then fuse to join and make the renal pelvis. So the renal pelvis would be here. B would be the pelvo-ureteric junction because it's just on the border of the renal pelvis, and then the proximal ureter. Yeah. And the question is, define the gender. You can see a coil or intrauterine system, and see it's a female. This is the image that I wanted to show you when it comes to all the little things. It's not the best resolution image, but this is what you need to know for the exam. I don't think you need to know more detail than this. So this is a calyx. This is a minor calyx. This entire thing would be a major calyx. Where they sort of join is called the infundibulum. Then this is the renal pelvis and proximal ureter. I think that's what you need to know. So using that same thing, A would be, apparently it's the infundibulum, but you can say just like upper pole major calyx. I think it's quite hard because, yeah, I remember when I was revising for this, like I was like, oh, what do I call it? Different answers say different things. I think you can probably just call it a left upper pole major calyx. These would be the minor calyxes, D. C would be the right renal pelvis. B would be the right lobe of the liver, and then E would be the distal ureter. So proximal is around here, mid, and then distal ureter. And this is the VUJ, so vesico-ureteric junction at the back of the urinary bladder. So A is the right kidney. You've got a bit of contrast still in the kidneys themselves. That's why they're quite bright, and that will eventually drain into the collecting system. B is the fornix of the right lower pole calyx. The fornix is just those little triangular things that then create the minor calyces. So this is a little fornix, this is a little fornix, and that creates a minor calyx. C is the left renal pelvis. D is the ureter draining the right upper pole renal moiety. And what this variant is called is a partial duplex collecting system of the right kidney. It's duplex and not a bifid ureter because there are two collecting systems. A bifid ureter would sort of like would create two ureters sort of after the level of the renal pelvis, but because this one has its own ureter, yeah, it's called a duplex system. Okay. We've gone through, I think, this during the thoracic lecture, but just to say it again, the first impression on a barium swallow is the aorta. The next one in the thorax is the left main bronchus, that's causing this impression. C is the left hemidiaphragm. D is the lower esophagus. Yeah, you know, if they point to that, it's called, I would just say a lower esophagus. And then E is the stomach. They've asked, I'm not going to go through these, but they've asked what variant is present. Whenever they show you an esophagram and there's some sort of indentation, it's always going to be a aberrant right subclavian artery. Although this isn't the typical picture of it, they normally give a sort of sagittal, and you can see posterior indentation of the esophagus. But whenever they say what's the variant at this level, that's the only one. So contrast is now in the stomach and it's going into the small bowel. A is the second part of the duodenum. It's showing this vertical part here, and so B would be the first part, or because they're pointing literally to the top surface, it would be the duodenal cap, you can say. C is the pylorus of the stomach. So actually the stomach is coming like here and up like that. And so this is the pylorus here, and this would be the antrum body. D is the jejunum, E is the ileum. Look at the walls of the jejunum. It's so much more featherier, the valvulae coniventes, whereas these are a little bit more spread apart and less feathery in appearance. So that's how you can tell something is jejunum or ileum. See, look how feathery this is compared to sort of ileum, which is more distal. But at this level, you know, A would be the ileum, B would be jejunum because of what we spoke about. C would be the second part of the duodenum because it's the descending part. D would be the pylorus, and then E would be, you can either say the first part or the duodenal cap. This is the other end, so this is via the anus. They've got a tube here, and they've put gas and contrast into the colon, and so they're just asking for the colonic anatomy here, so it's quite straightforward. A is rectum, E is sigmoid, this would be the descending colon, D is therefore transverse, C is ascending colon, and then B is the appendix. You see a little bit of this contrast has gone into this blind ending structure here, so it's the appendix. This is a sagittal image of a similar sort of scan. This is the sacrum, so this would be the presacral space. B would be the L5-S1 lumbosacral joint, L5-S1. D is the rectal folds or rectal valves. In the rectum, the Horstra basically call you know, you can say rectal folds or valves. Yeah. And then C would be the pubic tubercle because this is the anterior part of the pelvis here. And then it's asking what arteries supply the rectum, superior, middle, and inferior rectal arteries. So A would be the distal esophagus. I think it's quite hard to say, you know, where the diaphragm is on this, but because they've got two arrows, this would be the distal esophagus. This would be the cardia of the stomach, fundus of the stomach, body of the stomach, antrum, pylorus, and then C would be the second part of the duodenum. I wanted to show you this one just to show you C. So this is something called the incisura angularis of the stomach. Just say incisura angularis, and that's this little indentation at the lesser curvature of the stomach. Remember, this one's the lesser curvature, which is on the inner aspect of the stomach, and then this is the greater curvature. Greater is also bigger, so maybe that's the way, if you don't already know it, to remember it. This is, again, quite similar. E, just remember, is the greater curvature of the stomach. C is the angularis incisura, which we just mentioned. B is the pylorus, so this would be the first part, second part, third part of the duodenum, fourth part coming up here, and then this would be the duodeno DJ flexure here. It's got a bit of a flexure, and this would be the proximal duodenum. Yeah, remember the ligament of Treitz marks the DJ junction and the beginning of the jejunum, which is around here, where you've got a bit of an angle. Again, the incisura angularis is this here. Okay, so this is a urethrogram. So if you're at UCH, you will know this very well. The penile anatomy, penile urethral anatomy. So bladder filled with contrast here. You've got different parts of the urethra. This is the neck of the bladder. Okay, so the bladder is then emptying into this bulbous bit, which is called the prostatic urethra. 94 is the external sphincter. 93 is the bulbous urethra, and then 92 is the penile urethra. And then the membranous urethra would be at this level. I've got some other pictures. So this is the annotated diagram. So you've got the bladder, you've got the bladder neck here. You've got the prostatic urethra, which is the first part of the urethra. You've got the membranous urethra, which is the more narrow bit, just distal to that bulbous prostatic bit. Then you've got the bulbar urethra, and then you've got the penile urethra. The penile urethra is the external part of the urethra. I wanted to show you this because they can show you these. When you do these urethrograms, you sometimes see a little bit of contrast coming out from the sides. Those go into Cowper's glands, and then the little thing connecting the Cowper's glands is a duct. So you can say the duct of the Cowper glands, COWPER. These are also called bulbar urethral glands. This is a good level to see that this is the prostatic urethra, this is the membranous urethra, and then just immediately distal to that is the bulbous urethra and then the penile urethra. The membranous urethra is the shortest part. It's only from here to around here. So this is a HSP, so hysterosalpingogram. And what they do is they catheterize the cervix and then they inject contrast into the uterine cavity. This is often to look for like fallopian tube adhesions and sort of causes of subfertility. They don't do these as much anymore, it's my understanding, because they have other tests like MRI, but sometimes they do this to troubleshoot, is my understanding. So everything looks quite small in this. You got to imagine the uterus is actually quite big, and actually the cavity is quite small. So the uterus is coming out like this, but inside it's quite small. A is showing the fundus of the uterus. Maybe it's not coming out like here. Maybe it's coming out like this. But this contrast is only in the cavity. Remember that. So A is the fundus of the uterus. 2 is the right, so B is the right fallopian tube. C is the cervix. E is the isthmus of the left fallopian tube. That's just the proximal part of it. And then E is the vagina. This is what a HSP basically does. You catheterize the cervix and uterus, you put the contrast in, and then it will go into the fallopian tubes. And what you want is you want contrast dye to spill from the fimbriae. Peritoneal spill is a good thing. It means that it's not blocked. Like this. This is peritoneal spillage. These are the different parts of the fallopian tube. The isthmus, the ampulla, and then you've got fibra. I think I've got a better picture of this. Oh, maybe I don't. I think I do later on. So we're going to go through the abdominal vessels now. The first vessel that comes off the abdominal aorta is the celiac artery or celiac axis. You can say either or. I would call it this. If they're pointing just to this bit, you can call it the celiac axis or celiac trunk is what they've said here. The first branch going to the left is the splenic artery. Another one coming off the celiac axis, going to the lesser curvature of the stomach is the left gastric artery. You then have the common hepatic artery. The first branch coming inferiorly and supplying parts of the stomach and the pancreas is the gastroduodenal artery. That then creates the right gastroepiploic artery, and then the superior pancreatoduodenal artery. After the common hepatic artery, after this branch, you get the proper hepatic artery. Off the proper hepatic, you get the right and left hepatic arteries. You actually do need to know all of these, I think, for the exam. They could ask you the gastroduodenal, gastroepiploic, and superior pancreatoduodenal arteries for sure. The next vessel is the SMA, so superior mesenteric artery, which is here, but actually no, this is showing the celiac axis. So splenic artery, left gastric artery is coming here, common hepatic artery, gastroduodenal artery, hepatic artery proper, so that's PHA, and then that's got the left and right hepatic artery, and then you've got, the gastroepiploic artery, which is this thing that runs like this and then supplies parts of the stomach. The SMA, these are the main branches that you should know all. The first is the middle colic artery. Then you've got the right colic artery. These are the ones coming to the right. And then you've got the ileocolic artery. You've got towards the left, you've got the jejunal and ileal arteries. They're quite easy to sort of see which one's which because they basically supply what's in the name. The ileocolic artery supplies the distal ileum, so the ileocecal valve, and then a bit of the colon, like the cecum. The right colic artery supplies the ascending colon. The middle colic artery supplies the the hepatic flexure and most of the transverse colon to the level of the splenic flexure, and there's lots of anastomoses as well. So between these branches and between this and the IMA on this, you get these watershed areas, but then you also have collateral supply too. This is a picture of all of them actually, which is quite a good one. So it's celiac axis, SMA, IMA. The IMA is the most inferior branch, and the first branch of it is the left colic artery. You've got to think that the left side of the colon is yet to be supplied, so that's the first thing that comes off it. You get sigmoid arteries, and then you get the superior rectal artery. Remember, there are three rectal arteries, superior, middle, and inferior. The middle and inferior come off the internal iliac arteries, and then the superior comes off the IMA, and then you have anastomoses and collateral supply. So if one of these gets blocked, you often do get sort of like circulation and flow from other ones. The marginal artery of Drummond is the collateral supply and anastomosis that you see quite regularly in everyone between the SMA and the IMA. I think I mentioned before that off the femoral artery, you get the inferior epigastric arteries that come up and run up like this. And that's why when you do ascitic drains, you want to come in laterally so that you don't hit the epigastric vessels here. So some questions. This is a DSA aortogram. So you've got a catheter here, which is what A is, in the distal aorta. This patient has had a renal transplant, and this is what they do. They put the kidney in the right iliac fossa. They put the transplanted renal artery onto the external iliac artery on the right or on the left. This one's on the right. So aorta, common iliac artery, external iliac artery coming into the femoral artery, and then you've got the internal iliac artery here, which has several branches. This is a angiogram of the IMA. This is an AP image. This looks quite similar to the one that we just saw, and it almost looks like, when I was looking at this, it almost looks like a man with his hands like this, and then his legs like this, and then the hands join up. That's how I sort of like pictured it when I first saw it. And so when you see these, you've got to ask yourself, what artery is it first? And then you can work out all the branches. The IMA, remember, is the most inferior branch, and by this time we haven't yet, we need to supply the left part of the bowel. So this is the IMA. A is the left colic artery, which we mentioned. D is a sigmoid artery, supplying the sigmoid colon. This would be another one here. And then remember, B is the marginal artery of Drummond, which has anastomoses with the SMA. E is the superior rectal artery. That's got some branches down here and dividing and supplying the rectum here. So we've got another one. We've got to ask ourselves, what is this? This doesn't look like that man sort of standing on the side, like standing sideways, like here, that man's head standing sideways. This looks like almost like an octopus with sort of supplying lots of things, or like a sea creature with lots of tentacles. So A is the SMA. That's how you sort of remember it. Remember, the SMA is supplying things on the left, things on the right, and so that's why it's got branches bilaterally. Whereas the IMA is mainly the stuff in the left lower quadrant, right? So SMA, B is the right colic artery going towards the right colon. C is the ileocolic artery going towards the ilium and cecum. D is the left common iliac artery. You can see there's a bit of contrast that's sort of leaked or gone into this vessel, so common iliac artery, before it divides into the external and internal iliac arteries. And then E is the middle colic artery, supplying, remember, the transverse colon up until the splenic flexure. So this is a nice schematic that it's worth remembering. So this thing is the abdominal aorta, celiac axis has been cut, SMA is here, IMA has been cut. So SMA, the first branches are the middle colic artery, the right colic artery, the ileocolic artery, and then you've got jejunal and ileal branches as well. This is an MRA of the abdomen. This is the abdominal aorta. And then this branch is the SMA. You can see that it's coming down and supplying parts of the bowel. So the A would be the SMA. B is the gastroduodenal artery of the celiac axis. So the celiac axis is coming off here. It's giving this off, which is the splenic artery. It's giving this off, which is the common hepatic artery. C would be the hepatic artery proper, dividing into the left and right hepatic arteries. And so B would be the gastroduodenal artery. E is the left internal iliac artery. A, again, ask yourself, what is this? It's got that typical look of the celiac axis and in its arteries. So splenic artery has this tortuous sort of thing going towards the spleen in this direction. B is therefore the gastroduodenal artery, which is the first branch after the common hepatic artery. C is the hepatic artery proper, actually. And then actually E is interesting because contrast has already sort of gone around the body and it's started to collect in this structure, which is the right kidney, or the collecting system of the right kidney. So the right renal pelvis would be this, and then this would be the ureter. This is a good picture of the celiac axis, just to go through it again. You've got the left gastric artery, the splenic artery, which is quite tortuous, common hepatic artery, hepatic artery proper, dividing into the left and right hepatic arteries, the gastroduodenal artery, the superior pancreatoduodenal artery, and then the right gastroepiploic artery. You see how this looks like that man standing on the sides with his arms going up? So we know this is the IMA. The top branch would be the left colic artery. This is the IMA. C would be some sigmoid arteries supplying the sigmoid colon. D would be the superior rectal artery. And then when these things branch and they sort of anastomose, that's called the superior artery of Drummond. And this is a picture of that. These are all quite straightforward now for you guys. Remember, the two things going laterally and supplying the kidneys are the renal arteries. But this is a picture of that. And you know these by now. I wanted to show you this one because it's not a normal thing, and I don't think they're going to show it to you in the exam. This is, they've catheterized the right inferior phrenic artery, and I think it's really harsh if they give it to you in the exam, but it's been in some of the past questions. Yeah, look, I don't think they're going to give it to you, but going through it, the right inferior phrenic artery is A. B is the right adrenal gland. You can see that actually by this point, the arteries, the vessels are so small, and it's actually just perfusing the structure here, which would be the right adrenal gland. C is therefore the right superior suprarenal artery, i.e. supplying the right adrenal gland. I don't think they're going to show you this. They've also got a NG tube, and actually it looks like they've got like an acidic drain in situ as well. They've catheterized the right renal artery, so that's what A is. B is a division of the right renal artery. C is a segmental artery. So after the main divisions, you've got the segments. And then D is an interlobar artery. And E is an arcuate artery. Yeah, I don't think they're going to show it to you at this level, but those are what those structures are. Okay, I think let's do this one last time. We know this is the SMA because it's got all these tentacles supplying the left and the right. So A is the SMA, B is jejunal branches of the SMA. You know, the jejunum is in the left upper quadrant, so it makes sense. C is the iliac branches of the SMA, you know, supplying small bowel here. And then D is the right colic artery going down here. So this one would be the iliacolic artery here. Let's go over some biliary anatomy now. Actually, yeah, let's go over this. So this is an MRCP, and what they do with the MRCPs is it's like a really, really delayed T2 image. And so T2 images are bright, water is bright, and the bile content is watery. And so that's why anything with lots of water in it will be bright. And so this would actually be the stomach here, and then bits of bowel with fluid content inside them will also be bright, and then the biliary tree is also bright. So A would be the gallbladder. This is connecting the gallbladder and then the CBD, and so this would be the cystic duct. C would be the ampulla of Vater. D would be the CBD, common bile duct, and then E would be the pancreatic duct. A is the dorsal pancreatic duct, which in this variant is draining via the minor papilla here. B is the CBD, which remember always drains via the major papilla here. C is the left hepatic duct. You can't see the gallbladder, and so that's what this question is. There's no gallbladder, so they've had a cholecystectomy. And then the variant here is pancreas divisum, whereby the main pancreatic duct isn't draining via the major papilla, it's draining via the minor papilla and duct of Santorini. Again, this is an image of pancreas divisum. The main pancreatic duct draining via the minor papilla into the duodenum rather than via the major papilla. The head is still, this little duct here is still connecting with the CBD, draining the pancreatic head and then into the ampulla of Vater or major papilla. This person's got a gallbladder. This big structure here is the gallbladder. B is the common bile duct. E is the main pancreatic duct. D is the left hepatic duct. And then C, remember all structures with a bit of fluid in it will be bright on an MRCP. And so the thing in this area that also has fluid, apart from the structures which I've mentioned, is the collecting system of the right kidney. And so C is the proximal right ureter. You can now see that this is, calyces connecting to the renal pelvis, and then this is the ureter. This is an ERCP. We don't do these, but gastroenterologists do. And they like asking it in exams because it sort of throws people, but that's what this is. And so this is the OGD of that. So A is the common hepatic duct. It's yet to sort of join with the cystic duct and is yet to be extrahepatic, and so it's the common hepatic duct. E would be the cystic duct. B would be the left hepatic duct. C would be the common bile duct, and then we mentioned that this is the gallbladder. Let's look at some cross-sectional imaging. There's a few things on a CT I just want to show you. So you've probably gone through CTs by now. So I'll say the main things. Liver, spleen. Remember the adrenals are suprarenal glands, so they're just above these kidneys. This is the adrenal gland on the left. This is the adrenal gland on the right. and then these are the kidneys, as you know. The pancreas drapes over like this. So this is the pancreas here. It's not the best quality scan, but yeah, pancreas here. So unsynaptic process, pancreatic head, body, tail there. And then I wanted to show you some of the vessels that you should know. So you've got the right, middle, and left hepatic veins. You've got the portal vein here, which connects the splenic vein into the left and right portal vein here, and then sort of more distal branches. I then wanted to show you that you can see the SMV here. Sorry, I think earlier on I said the SMV should be to the left. It shouldn't. The SMV is to the right of the SMA. So this is the SMA here. This is the SMV here. Okay, and this orientation should be like it. Remember the snowman structure on the ultrasound, body of the snowman, head of the snowman. So this is SMA here, and then you can see IMA as well. So the inferior mesenteric artery is this. Sorry, vein is this. So inferior mesenteric vein, if we scroll up, that joins with the splenic vein here, and then the SMV here to then create the portal vein going into this. This is the appendix coming off the pole of the cecal pole. And then this is the ileocecal valve here. It's often more prominent and more fatty than on this in this case. But those are the things to bear in mind now when we look at the structures. This is a male patient, and so the prostate is just anterior to the rectum here at the lower part of the bladder. And then behind the bladder, you have these weird structures which look like a bit of a, yeah, they just look a bit strange. They're on the posterior part of the bladder, and these are your seminal vesicles. They're quite cystic, although you can't tell on this CT, but on MRI they're quite cystic, and so on T2 they're quite bright. And those are the things to bear in mind. Let's look at some cases and some questions. So the arteries, they can ask you not just on angiograms or DSAs, they can show you this. So you've got the aorta as A. You've got the celiac trunk or axis as C. You've got this tortuous splenic artery as E. D is the common hepatic artery, it's yet to branch. And then B is the gallbladder. You get this phenomenon called vicarious excretion of contrast. So this person may have had a contrast study earlier on today, or actually quite recently, and they've got a bit of contrast in the gallbladder. It's just one of the ways in which IV contrast is excreted. It's not just excreted exclusively by the kidneys, and this is called vicarious excretion. It's nothing to it, but it's something to comment on sometimes. Remember, right lower quadrant, this is going to be a blind ending structure. This is typical for the appendix here. B is the descending colon because it's in the left part of the abdomen. C is the right external oblique muscle. Remember, the most outermost lateral abdominal muscle is your external. Then you've got your internal, and then you've got your transverse oblique muscles. D is your left common iliac artery. It's splitting off, so up here is the aorta or B, and then it's splitting off into the right and to the left. And then E is your left ureter. The ureters, they go on top of the psoas muscles. So actually, if we go to the CT, this is the ureter. And remember, the ureters, they travel on top of the psoas muscles. So here, it's quite hard to see, but bear with me. It's coming here, here, here. You sort of lose it there. But remember, they travel on top of the psoas muscles. One is the coccyx, the lowest most bone. So A is the coccyx. B is the left femoral vein. Remember, it goes artery, vein, nerve, artery, vein. Sorry, nerve, artery, vein. So this is the right femoral nerve, artery, vein. So navy, NAV. Y is the sort of shape you make with your pelvis, NAV. C, this is from the lower limb lecture, but that would be your sartorius muscle. This is your prostate gland. And then E would be your internal left obturator internus muscle, which, yeah. So they've partially imaged this structure here. So this would be the head, sorry, yeah, head, Unser process, head, and then this would be your tail of the pancreas. That's what A is. B is something called a splenunculus. It's just an accessory spleen. It's got the same enhancement as the spleen, and that's why I know it's a splenunculus and not, for example, a tumor. C is the IVC. D is the splenic vein. You know, it's a splenic vein and not a splenic artery because the splenic arteries are super tortuous, whereas this is actually a lot smoother coming like this, and then eventually it'll go into the portal vein here. And then E is the left adrenal gland. IVC, aorta, spleen, stomach, base of the right lung. I think it's quite hard to say. I think you can say body or, yeah, gastric body if you wanted to. You can see that you've just captured like the base of the right lung there. This is a variant. It's a retroaortic left renal vein, so that's going behind the aorta. It should normally go anterior to the aorta, but this is a retroaortic left renal vein. The variant here is a duplex left kidney. They've got one ureter here and one ureter there. And this is a sort of urographic phase study whereby they've injected, they've waited, and eventually the contrast is being filtered out by the kidneys. You've got a ureter on that side. There's a bit of contrast in the calyces here, but you can see there's two dots here, and so you would know it's a duplex left kidney. This is something called a horseshoe kidney. This is whereby the right and left kidney are joined inferiorly by cortex, and basically this would be the IMA, and during fetal development it's basically gotten stuck at the level of the IMA, and these things haven't split into the right and left kidney properly. That's different to, for example, other variants which we'll talk about next, which is a cross-fused renal ectopia. This is whereby actually the kidneys are sort of like on the same side, and they're fused together rather than being held up at the level of the IMA. Yeah, that's the way to remember it. This is a left-sided IVC. That's the aorta, that's the IVC. This is nice round. This is slightly flattened like a vein would be, and this is on the wrong side. So this is a left-sided IVC variant. (31) is the left external iliac artery. You know, it's divided at this point. 32 is the gluteus maximus muscle. You see this muscle here, the big muscle of the bum with fatty striations. That's a gluteus maximus. This is medius. This is minimus. 33 is your internal iliac artery, which is split between the external and internal. And 35 is your rectum. So it's sigmoid colon coming down and then interrectum. We've got a few diverticulae here. (51) is your left superficial femoral artery. This is the profunda. This is the superficial femoral artery, which the femoral artery divides into. 52, the most anterior muscle, remember at this level, is your pectineus muscle. We went through this in the lower limb lecture. 54 would be the profunda femoris artery, which supplies some of the deeper structures, gluteus maximus. And 53 is the rectum, or anus actually, I would say, maybe at this level. It's quite low down. In the answers it says rectum, but I think I would say actually anus. and they've got a catheter. They've got a urinary catheter in situ. I wanted to show you this one, not for the structures, you know these probably by now, although this one they do like asking. This is your left quadratus lumborum muscle. It's got quite a unique shape and it's just lateral to the psoas major muscle. It's this. They've got a malrotated right kidney. The renal hilum should be facing medial, and so, you know, the renal hilum faces medial, the ureter comes down along the psoas. This is a malrotated kidney. They're at risk of things like hydronephrosis, for example, and renal stones as well, because the drainage is a little bit sort of convoluted, and so urine builds up and you've got more risk of stones. So these are the muscles that we mentioned. So 76 is the external oblique, 77 is the internal oblique, 78 is the IVC, quadratus lumborum, and then these ones, just call them the erectus spinalis muscles. This is an MRI. Structurally, you know, when you see an MRI, don't get thrown. All the structures are still in the same place. They can't move. And so, you know, take it back to first principles. Don't get thrown by the different look of the images. A would be the right lobe of your liver. B would be your transverse colon. C would be your IVC. D would be your left renal vein. Remember, the retroaortic one goes behind the aorta, so this is the normal position of the renal vein. And then E would be the cross of the diaphragm on the left. This structure here just like holds the diaphragm in place, and this is called the cross of the diaphragm. Again, a bit of lower limb stuff, but this fatty, streaky muscle here, which isn't sartorius, is your tensor fascia lata, which then creates your iliotibial band further down. A is therefore, right tensor fascia lata muscle. B is your iliopsoas. This is sartorius. This is rectus femoris. This is iliopsoas coming down and attaching to the lesser trochanter of the hip. C is your spermatic cord. So these are your femoral vessels here. So D is your artery, and this is your vein. This is your spermatic cord coming down and then sort of going into the scrotum. E is your rectus femoris muscle, just posterior to your sartorius muscle here. A are your inferior epigastric vessels. So they come off, remember, your common femoral artery and veins. And remember, they come up into the anterior abdomen, and that's why you do your acidic drains from this side and not directly straight down, just in case you hit them. B is your left external iliac vein. Remember, navy, nerve, artery, vein. E is your, these are your seminal vesicles. These are the posterior aspect of the urinary bladder. You've got one on this side, one on this side. The vas deferens then comes off this. Seminal vesicles produce some of the spermatic fluid that is needed. And then the vas deferens comes across here, does a few loops, and then goes into the spermatic cord and then travels down into the scrotum. D is your sacrum. So they're showing a structure here. It looks like bowel, and this is just a axial slice through that vertical bit of bowel, which we know is the second part of the duodenum. So this is your second part of the duodenum. B is your CBD. Remember, this is going to drain via the ampulla ovata into that second part of the duodenum. C is your SMA. Remember, aorta, SMA looks like a snowman. This is your SMV here, and this is how the axis should be. And D is the third layer of the lateral abdominal wall, which will be your transverse abdominis muscle. It's asking you what variant is present, and that is pancreas divisum. This is actually this looks like a duct. I think it's really, really hard to call. I don't think they're going to show you something like this. It's really, really hard to say what that is. But this is the major pancreatic duct draining not into this area, but into something a little bit further up, your minor papilla, and this is your major papilla. They won't show it that hard. They'll make it more obvious. The second part of the duodenum, this horizontal part is your third part here. B is, we started to talk about those fascias. This is your anterior renal fascia, so this is Gerota's fascia here. C is your lateral conal fascia. This is the arrow should point to this little structure here. That's your lateral colonal fracture, and this would be your descending colon here. And then D is your posterior renal fascia or zuccocandal fascia. I think you can say either sort of posterior renal fascia or zuccocandal. You'll get marks. So they're asking about the hepatic segments on this slice, and they've given you enough information to know that you should be able to differentiate which lobes these are. So this would be the right, this would be the middle, and this would be the left hepatic veins. And so A would be, and this is quite high up, remember, these are sort of like converging into the IVC, which is B. And so this is the lateral most upper segment, which would be segment 2. We're quite upper, and so, you know, remember, make that fist. C would be segment 7, D would be segment 8, and then E would be segment 4A. We're quite low down now. I think it's quite hard to say, but this is segment 4B. We're slightly further lower down because we can see the portal vein, so this is past that midline division. And also the falciform ligament would be here, and just lateral to that would be 4B at this level. E would therefore be segment 6. 5 would be in this region here. D is your caudate lobe. This is an IVC, this is IVC. Caudate lobe is the little structure just behind it directly. In front of it directly. B is your splenic artery. And then E is your spinal canal or spinal cord. D is, I want to show you this one, mainly for D, which is your hemiazygous vein. So on the CT, this would be your hemiazygous vein. And then this would be your zygous vein here. And that is also just draining some stuff in the abdomen. Often sort of the posterior parts of the abdomen are being drained by that rather than the bowel and the big abdominopelvic organs. I think we've done this sort of stuff now. I wanted to show you this because this is that epiploic foramen that divides the lesser and greater sac. A is the abdominal aorta, B is your psoas major, C is your Morrison's pouch. So it's asking you what space is this. So hepatorenal space is your Morrison's pouch, or you can just say hepatorenal space. And then D is your posterior renal fascia, so zuccocandal fascia. I know this is a little bit lateral, but we're not at the level of the colon, and so actually it's coming around here, and Gerota's fascia would be around here, or anterior renal fascia, zuccocandal fascia. A is, I think you can either say, apparently it's first part of the duodenum, but actually it's quite hard to say. It could still be pylorus. I think it's very difficult to say. C is your ligamentum teres here, which contains your ductus venosus, which is that part of embryological circulation that eventually would drain the umbilical vein. That's what that is. Again, this is a good picture of those fascias of the posterior retroperitoneum, sorry. So your colon ascending and descending here with your paracolic gutters. You've got your anterior renal fascia, your posterior renal fascia, so Gerota's and zuccocandals, and then you've got your lateral conal fascia here. And then your perirenal space is this area around the kidneys, contained within that fascia. So, perinephric fat stranding, this is the sort of area that gets your fat stranding when people have things like infections. I wanted to show you this image for A, which is your ischiorectal fossa. This is on the lateral side of the of the anus and rectum. So this space here is your ischiorectal space or fossa, and it just contains fat. Again, remember azygous and hemiazygous veins is what these are pointing to. C is your esophagus here. A is your left testicular vein. Remember, this is coming all the way from the testicle or ovary and then draining into the left renal vein. You can't actually tell on this slice if this is a man or a woman, so you would just have to say that this is the left gonadal vein. This is a coronal image, and then this is the lateral conal fascia here on a coronal image. They might show you something weird like this and ask about some structures in the thorax as well. Remember, A would be the inferior right pulmonary vein draining the right lower lung. B is your right hepatic vein. It's draining the right lobe of the liver, and so I think you can say that this is the right hepatic vein on this. C is your intrahepatic portion of your IBC. I think if it is within the liver clearly, ideally they'd show this arrow pointing a little bit higher up, but yeah, this would be the IBC, this would be the aorta, and D would be the left ventricle. So this is your SMA. This is a CT angiogram, and you can see that these branches are supplying some of the jejunum here. So E would be a jejunal branch. A is the actual SMA. B would be the SMV, just to the right of it. D would be the ileocolic branch. Remember, it looks like it's going towards the ileocecal valve, ileocolic region. And then C would be your ascending colon. Again, parts of the duodenum. This part is the second part, the vertical part. The horizontal part is the third part. And then the fourth part is when it starts to make that loop after it's crossed the midline. A is the inferior pole of the right kidney, or actually apparently it's pointing to the capsule, I think, or if you say inferior pole, that should be okay. This is the right renal artery. This is an MRA of this region, and you know this isn't a for example, ureter or anything like that, because it's got the same signal intensity as these, and there's nothing really which has fluid in it which has this signal intensity. These are the lumbar arteries which are coming off the aorta. D is the renal cortex. E is the renal medulla, or renal pyramids, you can say as well. Just as a bit of a sort of like curveball, this is clearly a MRI of the abdomen of a lady who's pregnant, and you can see the fetus. And, you know, first principles, you know, the head is facing down, so A is the fetal diaphragm. You can make out that that looks like the diaphragm. That's the globe. This is the placenta. So that's what the placenta looks like. You know, it's got these umbilical vessels coming off it, going into baby. And so, yeah, you know, from first principles, you can tell that this would have to be placenta. D is amniotic fluid, which surrounds baby. And then E is the maternal bladder, which is squished. Yeah. Just some sagittal images now, just to get your eye in, not because you don't know the anatomy, but just to get your eye in. A is the right acetabulum. No, it's not the femoral head at this point. This is part of the pelvis, so A is the right acetabulum. B is the gallbladder. C is the right rectus abdominis muscle because we're at the level of the gallbladder, so this is quite far to the right side, and so this would have to be the right side of that. And so you'd have to say that this is the right psoas major as well, okay, and right kidney. Specifically, I would say this is like an upper pole calyx. These are what the vessels look like, sort of branching off. So 44 would be the celiac axis, 45 would be the SMA, and then these are all other structures that you know. A is your S1 vertebral body, L5, S1, it looks like this, as we know. B would be your duodenum. C would be your lower lobe of the right lung, because we're towards the right, this would have to be the right lower lobe. D would be the IVC, because it's going through the liver, and this is IVC and not aorta because there's no vessels coming off anteriorly. E is the right renal artery. So the right renal artery goes posterior to the IVC. Again, we know that this is the aorta because these vessels are coming off. Celiac trunk, SMA. Apparently this is the left gastric artery. I don't think I'm going to show you something this difficult. I think it's very hard to say just on one image. D is the left renal vein. It goes underneath the SMA. Sometimes if people have lost a lot of weight, you can get something called nutcracker syndrome, and it's a cause for like a hydrocele, for example, on the left, and left-sided renal pain, and that's because this fat is less, and so this angle reduces, and the SMA can compress the left renal vein. Okay, let's go do some pelvic MRI stuff. But before that, let's look at some anatomy of some of the difficult structures. Ignore the circle and arrow. This is a schematic of the pelvic floor of a lady, of a female. You've got the urethra here, you've got the vagina here, you've got the muscles of the pelvic floor here. I don't think they're actually going to ask you these muscles. I think they're quite difficult to show, and they're quite hard to remember, to be honest with you. But this is the puborectalis muscle, so going from the pubis around the rectum, and then this is the pubococcygeus, going from the pubis up here to the coccyx. So pubococcygeus, puborectalis, and then iliococcygeus goes from the ilium around here to the coccyx. And then coccygeus is the one just at the back. I don't think they're going to ask you these, but just good for you to know. They could ask you this though. This is a schematic of the anal canal and anus. You've got two sphincters. You've got the external sphincter externally, and then the internal sphincter internally. That's the main thing to remember. And this is important when it comes to fistulas, perianal fistulas, which structures do these penetrate, and there's a few types because of it. This is apparently one way to remember this. So the internal anal sphincter, external anal sphincter, and then the levator ani muscle. Apparently if you've got this pointy sort of finger, it's this is the external anal sphincters, internal anal sphincter, and then the levator ani. I think they can ask you all three of these structures, so something to remember, this picture. I wanted to show you this because of the mesorectum. The rectum is surrounded by its own mesentery, called the mesorectum, which is a structure like this. And then around the rectum, you've got the mesorectal fat. Don't get that mixed up for the ischianal fat, which is further down around the anus, which we mentioned before. The mesorectum is very important for rectal cancers, whether or not it penetrates through the rectum, involves the mesorectum and then the mesorectal fascia. It's super important for rectal cancer staging, so that's why it's of clinical importance. This is a picture of a testicle, schematic. This is the testicle. I think actually we've gone through some of this, but the epididymis, the vas deferens comes, and then this sort of extends into the epididymis. You've got the head, which is the caput, but you can just call it the head of the epididymis. the body of the epididymis, and then you've got the tail of the epididymis. I don't think you need to call it caudal or caput. Head and tail is plenty. Then the testicle. You've got the tunica vaginalis, which is the structure that surrounds the testicle. And you've got the seminiferous tubuli inside it. You can't see these on MRI, but basically they're clinically important because if someone's testicle ruptures, because normally of trauma, then you've got a break in the tunica vaginalis, and then these leak out, and then the urologist has to pack them back in because this is like an immuno isolated place. And basically, if you've got these coming out, your body can make antibodies to your sperm, and then you can become infertile. This is a picture of the spermatic cord. Remember the seminal vesicles. From the seminal vesicles, the vas deferens comes around, loops around the pelvis, and then eventually enters the deep ring of the inguinal canal, creating the spermatic cord with all the vessels and whatnot. That then goes down into the inguinal canal, and then comes out the superficial ring and then into the scrotum here. And so a indirect hernia will follow the same route, remember? These are the main things to know about the penis. You've got the corpora cavernosa, which are the two things. It sort of looks like a sawn-off shotgun. And the two barrels are the corpora cavernosa, and then the bit of tissue that surrounds the urethra is the corpus spongiosum. And then this is important to know as well because they do ask this. The base of both of these, the corpora cavernosa, the base of them is called the crus, and then the base of the spongiosum is called the bulb. So all these things you should know, and it just looks a bit like a sawn-off shotgun, and so that's one way to remember it. The cavernosa and then the spongiosum. This is an image of the prostate, and I wanted to show it to you in a simplified way because don't overthink all the different structures. On MRI, you only need to know two. You need to know the central zone and the peripheral zone. All the other stuff, they really can't show you because it's not discernible on MRI. So if they show you this, the peripheral zone in the periphery, just call it the peripheral zone. And if it shows you centrally, mainly around the urethra, so the urethra will be coming through here. This is a coronal, so the urethra will be coming down like this. This is the central zone. And on T2, the peripheral zone is brighter than the central zone. And prostate cancer basically is normally the peripheral zone, and you get low signal areas of tissue in the peripheral zone normally. The female pelvic structures, we've sort of gone through this, but you've got the vagina, you've got the cervix, you've got the endocervical canal, you've got the uterine cavity, which is the extension of all this. Then you've got the endometrium, you've got the myometrium, and then you've got the serosa. The junctional zone is between the endometrium and myometrium, which you can see on MRI. This is that MRI. You've got the endometrium, which is this bright area here. You've got the myometrium, which is the outside, the big muscular area, and the zone between the two, which is darker, is the junctional zone, and then this dark band around the uterus is your serosa. This is the sagittal, this is the axial of the same thing. This is a schematic of the uterus. I remember in med school, I was really, I was like, oh, what are all the ligaments? It's so hard to remember. Honestly, they can't really show them to you. I think you can't really see them. I think that the round ligament is the ligament that comes, the female equivalent of like part of the spermatic cord that then goes into the inguinal canal and sort of helps tether the ovaries. So, that's what the round ligament does. But all these other ligaments you can't discern on imaging, and so you don't need to remember them. These are the different parts of the fallopian tube. So the isthmus is the first part as soon as it leaves the uterine cavity. And then you've got the ampulla sort of distally here where it reopens back up. The infundibulum is the distal aspect of it, and then the fimbriae are these. And then contrast when they do the salpingo, hysterosalpingograms, comes and spills into the peritoneal cavity. This round ligament is that ligament that I say you can see. Okay, let's go through some cases. 46 is the right obturator internus muscle. It's on the inner walls of the pelvis. So this muscle that comes like this is the obturator internus muscle. 47 is the left levator ani muscle. 48 is the ischial-anal fat or space. 49 is the external anal sphincter. And 50 is the right ischium. If you remember that picture of the hand, levator ani, 49 is the external anal sphincter, and this would be the internal anal sphincter, just deep to it. This is the sagittal image. 91 is the bladder. 92 is the mesorectum. Remember, if they show you some fat here, I think you can also say presacral space, but around the rectum is the mesorectum. It's quite difficult. I think I would, in an exam, I would have said presacral space because it's just before the sacrum. But if they ask you what sort of structure it is, rather than space, then maybe say the mesorectum. 93 is the endometrium, that sort of bright stripe. And then 95 is the vagina. Remember, this is the cervix, this is the vagina. '66 is the mesorectum or mesorectal fat. This is sort of the distal end of the rectum, but you see how you can imagine that if there's a rectal cancer, when it penetrates through this and then the mesorectal fascia, then it becomes of more importance. So mesorectum. 67 is the prostate, but it's like the most inferior part of it. So I think, I'd say you could say prostate. That is what they've written. 68 is the left obturator internus muscle. 69 is the corpus cavernosum on the left. These are the paired structures, so this is the left one. And 70 is the left gluteus maximus muscle. '16 is your pubic symphysis. 17 is that ischial-anal fat or fossa. Remember, this is the mesorectal fascia, which would be, actually this is quite low down so you can't see it, but this is that ischial-anal fossa, not to get mixed up. 18 is, this is your prostate gland. Remember what I said, the peripheral zone and the central zone? This is how they're going to show it to you. Nothing more detailed than that. So this would be the peripheral zone of the prostate gland is what I would say. And then 19 is the most anterior muscle in this area, which is called your pectineus muscle. 20 is your spermatic cord, which is coming through and exiting via the superficial ring. A is your rectum. B is your rectovesical pouch. So this is your pouch of Douglas. In women, remember, pregnant ladies, if you get fluid here, after delivery, it could suggest hematoma, but basically you get fluid in this region. Sorry, pouch of Douglas is between the uterus. This is the male. So actually that would be the rectouterine pouch. So this is the rectovesical pouch, which everyone will have. C is your corpus cavernosa. The spongiosum is at the bottom of it. The cavernosa are on top. You can't tell which side this is. D would be a testicle. '11 is your sacrum or sacral promontory. On a sagittal, this part of the sacrum would be sticking out, but I think if you say sacrum, you'll get the points. 13 is your obturator externus muscle. We went through these in the lower limb lecture, so I'm not going to stress it. 14 is the gluteus medius muscle, minimus, medius, and this isn't maximus because maximus has that sort of like marbled appearance to it, and so that's how you know this isn't maximus. 15 is your vastus lateralis muscle. Again, we discussed this before. This is the sacral promontory that's sort of sticking out. That's what this part of the S1 vertebral body is called. B is the vagina. C is the posterior fornix of the vagina. This little bit here that sort of goes posterior behind the posterior part of the cervix is called your posterior fornix. D is the external os of the cervix. So external, internal will be between the cervix and then the uterus. So external os is cervix. A would be your junctional zone between your endometrium and myometrium. B would be your endometrium. C is your collapsed urinary bladder. D would be your external os of the cervix. And then, yeah, E was the myometrium. This is what the seminal vesicles looks like on MRI. Those cystic structures, which you couldn't really tell they were cystic on CT, but this is what they look like on MRI. Don't get these mixed up for an ovary. Okay, so you know, an ovary would also have cysts, but this looks quite different to an ovary. And again, this is the prostate gland, central zone, peripheral zone, all you need to know. This is the levator ani muscle there, and this is the ischio-anal fossa, or fat, on the left. So this is a male patient. You've got the cavernosa and spongiosis here. Again, cavernosa spongiosum, spermatic cord coming down there. Bladder, central zone, peripheral zone of the prostate. This is just a coronal image of that. C is the levator ani muscle coming like this as well. Although we covered this in the lower limb lecture, I'm just going to say a few things. A is your adductor longus muscle. B is your gluteus maximus. Remember, it's got a little bit of fat marbling. C is your right ischium. D is your quadratus femoris muscle, which is between the ischium and then the femur, which comes like this. And sometimes this can be impinged in certain syndromes. I wanted to show you this because just a bit of an aid memoir if they're asking about the adductor muscles. The way to think about it is it gets progressively bigger the more posterior you get. So the first one you'd get is adductor brevis. So the first most anterior one would be pectineus, which maybe it's not imaged here, but the way to remember it is it goes pectineus, brevis, longus, magnus. Brevis is the smallest, longus is longer, and then magnus is the biggest. Remember, these are what the seminal vesicles look like and not ovaries. So going through that again, this is a T1 image, and so the bladder has urine, and this is dark, and so just behind the bladder you've got the seminal vesicles, which looks very different to this because it's a T1 image. So A would be your left seminal vesicle, B would be your mesorectal fascia, so remember this is the mesorectum surrounding the rectum. E is your coccygeus muscle back here, which goes, attaches to the coccyx from the ischial spine, which is this. So ischial spine to coccyx is your coccygeus muscle. Okay, so the final one is this. So A is your spermatic cord on the right. This is the spermatic cord on the left with a bit of fat which is herniated into this. So you just call this a small fat containing hernia in your reports. B is your right, the crus of your right corpus cavernosum. So this is the corpus cavernosum. When it gets past here, where it attaches is called the crus of the corpus cavernosa. The spongiosum is called the bulb when it attaches here. C is your right inferior pubic ramus. D is your anal canal, or anus, I think you could say. And then E is lastly your gluteus maximus. And you can see the fact that it's got a bit of fat marbling. That's why you know it's maximus and it's right at the back. So that's the end of that.